Welcome to Peter and Phil's Courageous Conversations, a podcast addressing race relations and social issues in hopes that you'll be inspired to do the same. Now, let's begin our conversation with your hosts, Dr. Peter Weinstein and Dr. Phillip Nelson.
Welcome back to Courageous Conversations. I'm Dr. Peter Weinstein.
And I'm Dr. Phillip Nelson.
And we are here with some guests, without whom we may not be here. But with their support, we have been able to continue for almost 4 years now, a conversation about world and veterinary issues. And so before we get started and introduce our guests, I want to thank Nationwide for their support of the Courageous Conversation podcast. I want to thank Nicole for her due diligence in making us sound and look a lot better than we actually do. And I want to thank our audience, or all 11 of you, for listening in on a regular basis. And now that we're up to double digits, next goal is triple digits. Phil?
Yeah, so how have things been going, Dr. Weinstein?
Busy. No, life is good. The world is good, as long as you don't watch TV. I have plenty of things to keep me distracted besides the news. So I'm a happy camper right now. I want to start with the focus is introducing and welcoming our guests. Phil?
Yeah, so last week we actually got a primer from Dr. Weinstein and on veterinary economics. And it caused us to cover a lot of things superficially, but now we have some experts with us. Dr. Jules Benson, who's here with Nationwide, and Dr. Emily Tincher were the ones who decided that this conversation was worth support. And we want to express our appreciation to both of them for sticking with us for the last 3 years. But it's not just the financial support that they've provided for us that we think they're special people. They're also very skilled in what they do. I'll let them explain what they do, but we're actually followers of them and don't always agree with everything that they approach, but they are now actually considered some of the leaders in the profession when it comes to spectrum of care, as well as breed-related diseases. And those are some of the areas that I think we might want to talk about today. But first, Dr. Benson, Dr. Tincher, welcome, and
Thanks.
Say hello to the audience.
Thank you very much. It's a pleasure to be here. I always enjoy spending time with you, and Dr. Tincher and I get to spend a lot of time together. But it's always good to join this group and have a good conversation. So really looking forward to chatting.
Dr. Tincher.
Chatting with y'all. I know we get to see you both sometimes live out in the world, but we really value our conversations that are winding as they are on this podcast. And exploratory. So looking forward to seeing where it goes.
So I'm Jules Benson. For those who don't know me, I'm the Chief Veterinary Officer at Nationwide, and I will allow Dr. Tincher to introduce herself, since I will mess it up otherwise.
Hey, I'm Dr. Emily Tincher. My pronouns are she, her, and my role at Nationwide is Senior Director of Pet Health.
So as I was saying, last week, spectrum of health came up, and I'd like for you all to give us your definition of spectrum of health. I find it sometimes ironic when Dr. Rustin at Ohio State, do you mean
the Ohio State, Dr. Nelson?
I did not mean that, but I should have. The Ohio State staff. A lot of times when he talks about spectrum of health, he begins with, he doesn't like the term, that it is an apt description of something that has been in place or for as long as the profession has, in his opinion. It's the re-emphasis, however, that has forced us to name it, to name the possible modalities of therapy.
I'm going to let Dr. Tincher handle this one, and we have strong thoughts for and against on Dean Moore's stance on that, I would suspect.
Good, I bet. I just thought I'd bring that in and see just where you all stand. Dr. Tincher.
Yeah, so I think it's not necessarily our definition of spectrum of care. I just want to put that out there. Spectrum of care has a published definition, but what we have done is pulled it together and maybe tweaked a couple of the words. And so spectrum of care is taking the needs of pet families, meeting pet families where they are with a range of options from basic to advanced that takes into account their goals, values, and resources. And what I really like about having a published definition, again, pulled from a couple of different sources put together, is that there's also a published method of following it. What is how do you do this thing that we just said out loud? And there are three main components, and that's identifying pet family goals, values, and resources, including finances, of course, but other things as well. That's understanding with the pet in front of you, what are the evidence-based medicine options available to you and identifying them. Usually 3 is a great magic number. What are 3 options across that spectrum, all of which meet a standard of care, so that minimum that we have to provide, and then saying, some more basic options, potentially more advanced options. Sometimes that even means referral. And then providing those options, contextualizing them to the pet and the family in front of you in the exam room, and having a pet family centered communication. So that's using all of those evidence-based communication skills, open-ended questions, active and reflective listening, and it's very actively ensuring that we're not conveying judgment no matter what the option is chosen from the pet family in front of us. So having that method of these are the things that you have to do to practice a spectrum of care, I think there are 2 pieces to bring out from how you ask the question. And one of them is the term itself. And I think it's really interesting. So in the UK, the term contextualized care is really much more popular for the same thing. They're synonyms. However, and I kind of like it better. Like I think it much more appropriately.
You like which better?
Contextualized care. I
Okay.
like it a lot. Contextualized care describes what you're doing when you're
Yes.
practicing a spectrum of care. You are taking every single case and you're personalizing your approach to them. What contextualized care, at least currently, is lacking is that published definition or a published methodology of how to do it. And so to me, they're synonyms. I don't have like spectrum of care is maybe a little more academic sounding. There's been a lot of there's been active coalitions across industry, across academia, across associations, funding organizations like the Stanton Foundation have really rallied behind the term of a spectrum of care. And to me, words matter. I think like y'all talk about words matter more in a really healthy and productive way. And I'm very curious to hear your thoughts on this as well. I think the difference to me between contextualized care and spectrum of care in the words is so minimal that I don't personally want to distract from doing the work to say we need a rebranding campaign for spectrum of care in the US from a terminology perspective. So would love to hear your thoughts on that. And then we do have thoughts about, is this what we've always done? And we should come back to that.
Yes, we should. Great.
I want to do a shout out before we get too deep into this, and also a resource to expand on what Emily was talking about. And I hope you guys don't mind if I use your first names instead of doctor, because I think we've known each other long enough that we're on the second date at least. Vet Clinics of North America, which came out this spring, has an entire volume on practice management. I had the honor to be the editor for it. Thank you, Emily. Get a picture of that, Nicole. And I, with some trepidation but great honor, asked Jules and Emily to thank you. Mine's behind me over there. I asked Jules and Emily to co-author a chapter on this topic. And the chapter is entitled Cost of Care, Access to Care, and Payment Options in Veterinary Practice. It helps with some of these definitions. It has some great discussion and studies. I know that they put a lot of time and effort into it. And as with any book, it's not the writing, it's the rewriting and the editing. But I do think it's a great resource to access to help have a better understanding all in one place with definitions such as spectrum of care. And there's a good historical perspective in there as well. And I think we'll touch on that in just a minute. But I want to give a shout out for their efforts in putting that chapter out and continuing to speak on the content that's within it. So thank you.
I think all I heard, other than the thank you, was that he did more work than you did.
So this is a funny story, Phil. So as we have the guidelines for this, and we asked for more time. Like this was very much I have huge respect for those in academia who are constantly writing, papers and book chapters. It's hard. It's really hard. It's a lot of work. And this really was like I won't say a labor of love because it was involving Peter, but it really was like, this was a lot of late nights and weekends of, to your point, writing. And then we got to the point of like, well, we have 9,000 words for was it 5,000 it was supposed to be?
Yeah.
And we're like, we want to make sure that we don't put Peter in a bad spot. And we'll kill our babies, to get this down to size. And then we meet him in whichever conference it was. It's like, yeah, I just submitted 9,000 words and let them deal with it. I'm like, dude.
You know what we did?
Yeah.
Well, you're more likely to receive forgiveness than permission. That's what I did.
We were just worried you'd take the wrong parts out of it, I guess. That was our concern of like, let's make sure that we have the best parts. It really is our partnership, it really is a really good synthesis of, I think, her expertise and her experience and her real depth of knowledge around spectrum of care and access to care. And I think we complement each other well. I think we both have a really good understanding of that area. And then I try and bring the data side in, which we talked about a little bit in the beginning. But I think we have this really good kind of cross-pollination of coming at it from slightly different perspectives, but also having a pretty shared brain space around these things. So having worked in general practice and Emily being a second generation veterinarian of basically growing up from the age of 0 in primary practice in rural Kentucky, I think we both have perspectives on what it means to be in general practice. And I think I was so lucky. It was actually, I'll give a shout out to Dr. Drew Sporer at Doylestown Animal Medical Clinic, who was my mentor in general practice. He just texted me recently. It was great to hear from him. But they were, I think, a really great place to learn. And I think so much of what we see in Spectrum of Care resonates around their approach to care, which really was, let's consider the options, let's understand the client in front of us. And Peter, you talk a lot about relationships in veterinary medicine and that being the core of our medical practice. And I think Drew and the crew at DAMC really lived that. And I think the biggest difference, and maybe this has been a journey for us. I think originally we were like, you know what, this is very similar to the way that a lot of us have practiced, of giving options and making sure that people understand them. But I think the key difference really is that communications portion, that non-judgmental communications. And unless you're embracing a manner of communication that is non-judgmental at its core for all members of the veterinary team, but based on the current definition, then you are not practicing a spectrum of care. You're not embracing that process fully. So I think you can offer options. You can, try and have an understanding of what the needs of the client are. But unless you're really taking that extra step to embrace that non-judgmental communication, I think that's the biggest difference between what we see as like, well, 20 years ago I was practicing and it feels like, well, I was doing spectrum of care. But then unless you're investing the time and the effort in really making that next step in the communications aspect, I think that's the biggest difference that we see. And I think the biggest point that we make now when we speak about it publicly.
I think it's a really useful example of what is helpful about publication and peer-reviewed, having outcomes that we measure, which we still struggle with a bit in this area, but it's an even better yet, basically, to how we used to practice. I did absolutely learn to understand and value what it looks like to practice across the spectrum of care by watching my parents growing up. And I think that the even better yet, because we have the definition, means we can level up. And it's not that anyone's doing anything wrong by practicing as they have been. We have the opportunity to, I think what's so cool about a spectrum of care is it puts the pet family, not just the pet, which is the medical outcome, but the pet family in the center of everything that we do. And so how do some of us just slightly shift, adjust how we're engaging with pet families. And then I think another area we're really interested in, and Jules is speaking at very soon at Cornell, is how do you measure that? How do you say our success, if our success is putting the pet family at the center of everything that we do, combining the medical outcome with the client's perception of the outcome, what does that look like? And what are kind of the next phases of bringing that data component back in? So
first of all, I want to say that, Emily, that was probably the most eloquent expression of spectrum of care I've heard. ever in terms of the completeness of the definition and the connection with outcomes. I think the problems that we have with the term spectrum of care, first of all, it can be prescriptive, and I personally like contextualized care as well, because it caps the activity of the collaborative process between the client and the veterinarian and veterinary team in determining the intervention and affecting the medical outcome. And I agree that is the key. Whether we've been doing this or not, we have to for a while or not is immaterial. It's kind of like fighting over the name. As long as we understand that there has been a social change in medicine. Mm-hmm. I was very fortunate. I have to give a shout out to Dr. Larry Weed, who created the medical record system, the problem-based medical record system in human medicine, and then sold it to VetMed. And I happened to cross his path for about 15 years before he died. And he was a great man. But one of the things, he was the first role model that understood the collaborative process of patient-doctor relationships. And he used to give a lot of analogies and said, he would say, why would you get on an airplane where the pilot didn't know where you were going?
Yeah.
And why would you go to a doctor and depend on the doctor to tell you what's wrong with you when you know best what actually hurts or what actually works for you?
We've talked about spectrum of care. I don't know that we've talked about what problems we're trying to address with it. And I think that's, to your point, Phil, there's a worthwhile conversation around what are the things that are important to pet families and what does the future of veterinary medicine look like? And, as we cover in the book chapter, access to care is a big umbrella, right? It includes everything from vaccine clinics, which, Peter, I know you have a lot of experience with your volunteer work, all the way through to, do people have access to, precision oncology? Like that's also an access to care issue, but it's the very other far end of the spectrum. And so when we look at, and we kind of go through what does the cost of care look like? And the cost of care, the cost of veterinary care has been pretty terrifying over the past 20 years. When we look at it from the consumer price index point of view, and I think the power of the dollar in terms of buying something in a veterinary clinic is 61% more poor than it is for the rest of all goods on the consumer price index, which means that $100 20 years ago it doesn't go anywhere near as far in a veterinary clinic as it does in the rest of the world. And we talk about the reasons behind this inflation is not, and this is something that when we're nationwide, I think we talk about whether it's rates increasing or anything else. This is not your vet is putting your prices up because they're trying to line their pockets. This is look at all the issues we have at the moment driving inflationary pressure, and it's staffing issues, it's availability of medications and supply chain still hung over from COVID. It's our explosion in diagnostics and treatments. Like we're seeing that now with fantastic drugs, like the monoclonals that have come out for cats and dogs. It's a great option, but that's going to increase the cost of care for a lot of people. Now, are we getting an increase in care for our pets that's commensurate with that? That's certainly what the market's telling us, but it doesn't mean that fewer and fewer people can afford that level of care. Probably, right?
Yeah,
so
I would even say that the collaborative efforts that we're talking about may require, there's only so much time in a day. It may require a few more people to deliver that type of care, which adds to the expense.
Who are the people that are doing that work? I think as we come back to what Jules just mentioned, staffing. If we all agree, we all agree that we need to pay our credentialed technician, our veterinary assistants, our receptionists more, a living wage that keeps them in our field and in our practices, much less, feeling like they have to leave for a career that will allow them to retire ever, much less at a reasonable age. Then by allowing people to do the maximum that they can, and a lot of the additional part of maybe that extra time, I want to come back to that efficiency. Some of that extra time is communication that doesn't need to happen at the veterinarian level. It needs to happen at the technician level. This is full staff training that I don't know if I really would love, we're not in a place, we don't have practices, we're not in a place to do that study, but I would really love to understand the hypothesis that I have is that practicing a spectrum of care may be more efficient. And that's because if you're listening, it kind of goes back to the myth that was previously pervasive of, asking open-ended questions will take longer. Well, you get better information. So it actually takes less time and you're more likely to get to that correct diagnosis by asking open-ended questions. If we target and try and identify what is it that pet families are looking for as quickly as possible, instead of trying to convince them what we want them to do, what are the efficiencies, the operational efficiencies that could come from that?
Yeah, and don't get me wrong, I'm not saying that more time is not worth it but as you said, if I'm going to value or provide a more experience for our technicians or our staff to be involve them more, I'm going to pay them more, and I'm going to reflect that value in their pay.
And I think there's a great point about spectrum of care. I think the automatic assumption is that if we're not pushing people towards the most advanced level of care automatically, that a spectrum of care, consequently means that we have lower revenues. Now there's some great work that's not been published yet by the American Association of Veterinary Medical Colleges, and they have an awesome team there working on spectrum of care that we've really enjoyed working with over the past couple of years. Again, supported by a grant from the Stanton Foundation. It's our current belief and hypothesis, and we're waiting for the figures from AVMC that spectrum of care doesn't mean that. And actually, as we look at compensation models, and it's a big area that I think we have conversations about internally, that if we look at when we speak in conferences about things like intermediate surgeries, whether that's a perineal urethrostomy, whether that's a lateral suture on a cruise ship, right? Whether it's even things like foreign bodies. I feel like
body surgery,
even things like foreign body, like the last 20 years has seen more and more of a movement to referral, right? And I think we see that everywhere. When we ask people in audiences, how many of them have access to a PU in practice, how many of them access to a lateral suture, it is vanishingly small numbers. And this is obviously complicated by the fact that we have staffing issues at the moment. But let's assume that if we give veterinarians the confidence to practice at that intermediate level, to step up, especially in places like surgery or even internal medicine, our belief is that actually practicing a spectrum of care could actually be better for practice revenue than if we're pushing the most advanced level of care. And I know there'll be a pushback on the specialist side, but specialists have as much work as they can handle at the moment is the impression I get based on the ones that we've spoken to. And we're actually even hearing some of the specialists. There was a great trying to remember the name of the neurologist on Dr. Andy Rock's show last year. And he's basically saying, like, stop sending us stuff. Like, there's things that you can do. Like, you stop sending me, relatively simple or even moderately complex seizure cases. Like, those are things that you can and should be doing in general practice. But we as specialists, in some cases, have robbed you of the confidence to manage those cases. So I think that goes hand in hand with being able to practice spectrum of care in general practice.
Well, I totally agree. I think part of the problem is the balance of how we approach this, right? We have people that we're underutilizing, and now you've just included the veterinarian, him or herself, right? As being underutilized. I have been, as an academic, I've been a bit of a heretic in trying to tell students that you can do a lot more in general practice than is being referred. But the unproven premise is that the more cases I get to see, the more money I make. And it's not the more cases I take to fruition will affect my income positively.
So we've got cases and we've got people. Yeah, and I think separating those two things, especially in a general practice environment, Emily, I jumped in. I saw you eager to give comment. I'll exceed.
No, go ahead and finish that. I was just going to comment on the average client transaction of I don't know if it is always, it's maximizing. I mean, how do we measure our success as doctors right now?
Yeah. Well, that's why I said the unproven premise.
Well, sometimes I think right now we measure it by average client transaction and production. And there's I remember being maybe middle school aged child, and my parents were going through management training and had been told directly that like if you have a higher average client transaction, then you're a better doctor. That those two things equated. And that's absolutely how we're compensating right now. That if you have a higher average client transaction, then you're a better doctor. I think the question to me is, you can be profitable, you can see more patients and have a smaller average client transaction, or you can have more surgery cases and have a greater average client transaction because it's surgery. It's something that needs to be done, and you're keeping that in your general practice. A lot of different ways to adjust along that, and decoupling our worth and how we compensate from maximizing what is on an individual invoice seems like it will be helpful for both providing care, again, putting pet families at the center, and maybe also our own well-being.
Yeah, but you just brought in the opposite of what I was saying. I was actually running more paces through without, which actually lowers the average per transaction, because you're just trying to see as many as you can per hour. I definitely don't think that equates to being a better doctor.
I think when we did some research, I think it's a really interesting perspective, Phil. I think when we look at, and we've had some really interesting commentary on the corporatization and the VC and the PE side of medicine at this point, and are we in danger of transactionalizing veterinary medicine and getting further away from, again, I know, Peter, this is a big topic for you of the relationship side of veterinary medicine. And I think when you, and I can't remember what the example was, Emily, we had talked about this with somebody, and the difference in trust that people have when they feel like, they're having a conversation about their goals and aims versus, and this can be completely well-intentioned from our point of view to be driving to the basket for like the best medical outcomes. Like that can be completely well-intentioned on our side and have nothing to do with revenue or income or productivity, but it can certainly feel to the client like we are being very judgmental and that we have there's one way of doing this the right way, and if you're not doing that, then this is basically you being not a great pet parent. And I think looking back on my days in practice, I think I was definitely guilty of that. And Peter, I mean, we talk about stories of, I think, when you were running your practice, of just of having those metrics in mind around running the practice that really were so production focused. And I don't know if you want to talk about, how your mindset changed over time on that, but I think it's really interesting.
After 30 years in this field and looking at it from a variety of different perspectives, I realized that in many cases when I was in practice as the owner, my focus was top line, bottom line. You had a staff to pay, you had overhead to take care of, and you wanted to have a return on your investment. And so really, to get to revenue, you either see fewer people at a higher price or more people at a lower price. I mean, that's it. Earns or turns, thank you, Mike Dix. But over time, you have to realize, and I saw this in my own practice over time, that it's really about the lifetime relationship that we're trying to build, which is relationship-based, not transactional. And so the ultimate real measure, and I do a whole talk on this, the real measure of success shouldn't be average client transaction or annual revenue. It should be patient lifetime value, which is how much money that patient brings to your practice over its potential life expectancy, which measures your quality of patient care, clinical care, relationship building, frequency of visits, a whole bunch of different parameters that really are all about communication. It's all about building and retaining the relationship. So,
and I would push that we can quantify that by potentially changing relationship to value.
Correct.
Right? When we talk about client reported outcome measures or those other ways of measuring how successful we've been in managing that client and their expectations and their pet's health, I don't think we have to be, you and I have a personal relationship I think that's an easy way to build relationships with people, but you can build value-based relationships as an organization. And I think, so you've been talking to the folks from Modern Animal, and I think they're coming at this very consciously from how do we provide a value base that appeals to you, and that we are a honest broker in this transaction of value around you and your pet's health.
Well, the component that I wanted to get to is team-based healthcare, which is really the way it's best driven. We have to move away from the doctor-centric business model of my era and Emily's parents' era, which is probably about the same era. We made the same error because we're in the same era. And look at team-based healthcare and have clients coming in looking to see our credentialed technicians and our client service people and going to them with the phone calls for problem solving and not just the doctor. So the true long-term success of the profession is not going to be based upon a doctor-centric business model. It's going to be based upon a client-centric business model driven by a team-based healthcare approach.
And I think you can do that in corporate medicine. Like, I don't think those two things are antithetical. Like, I think you can build successful team-based medicine within corporate medicine. But again, you probably have to look at the long-term view, and it may take more data around things like spectrum of care to be able to say, and this was one terrifying thing we heard in the we did our innovation team at Nationwide did some research about 4 or 5 years ago now, but some of the deep qualitative research, it was horrifying to hear that people had a view of their veterinary experience as feeling like they were in a used car lot, like that they were being sold a bill of goods because of the transactional nature of their experience at the clinic. And I think all of us, quake to hear that's something that our profession could be, equated to. But that's the reality of some experiences. And I think the more we depersonalize these things by not allowing a team-based approach that takes into account the needs and the goals and the values of the pet family, that's where we're going to continue to get ourselves into trouble.
That's a great place to take a quick break and convene with that conversation in just a minute. I think we have actually moved, interestingly enough, from the contextualized care, which by the way, my vote is I like that as well, if we can learn how to spell contextualized, you have to spell it. Through spectrum of care, through access to care, and through a kind of different healthcare delivery models. And I think that's a great place to take a break. And again, thank Nationwide for their support. We're going to pick this conversation up next week. And thank you, Phil, for allowing me to have a voice towards the end of this discussion. Phil, any final words before we take a quick break?
It didn't work. I was trying to carve you out for the next one, but that's okay. No, we want to thank our guests, and we're going to continue this discussion in our next episode. Please come back.
Thank you for joining us for another courageous conversation. Be sure to follow us and check back next week for more.